Frozen shoulder, adhesive capsulitis. A scientific analysis. Frozen shoulder, or adhesive capsulitis, is a debilitating condition characterized by progressive pain, stiffness, and loss of passive and active range of motion, ROM, in the glenohumeral joint. It primarily affects individuals aged 40 to 60 years, with a higher prevalence in women and diabetics, incidence up to 20% in diabetic patients. The condition progresses through 3 overlapping phases. 1. Freezing, painful phase, 2 to 9 months. Severe inflammatory synovitis leads to pain at rest and movement, particularly at night. The joint capsule thickens due to fibroblast proliferation and collagen deposition, reducing joint volume. Cytokines, IL-1, IL-6, TNF-alpha, and growth factors, TGF-beta, drive fibrosis. 2. Frozen, stiff phase, 4 to 12 months. Pain decreases, but stiffness worsens due to capsular contracture. Fibrotic adhesions form between the synovium and articular cartilage, restricting motion. Histopathology shows hypervascular synovitis and collagen cross-linking, leading to a stiff, contracted capsule. 3. Thawing, recovery, phase, 5 to 24 months. Gradual remodeling of collagen improves mobility. Spontaneous recovery occurs in most cases, but some patients retain residual stiffness. Pathophysiology and molecular mechanisms. Fibrosis and capsular changes. The rotator interval and axillary pouch are most affected. Myofibroblast activation increases alpha smooth muscle actin, alpha SMA, causing contracture. Abnormal collagen, type 3 greater than type 1, deposition disrupts tissue elasticity. Neurogenic inflammation, substance P, and calcitonin gene-related peptide, CGRP, contribute to chronic pain sensitization. Sympathetic dysregulation may explain persistent pain in some cases. Biomechanical alterations. Reduced joint volume from approximately 30 milliliters to less than 10 milliliters due to adhesions. Capsular stiffness restricts external rotation and abduction most severely. Risk factors. Diabetes, 5 times higher risk due to advanced glycation end products. AGEs, promoting fibrosis. Thyroid disorders. Parkinson's, prolonged immobilization. Treatment approaches. Conservative. NSAIDs, corticosteroids, oral intraarticular to reduce inflammation. Physical therapy, stretching, hydrodilation to improve ROM. Advanced. Manipulation under anesthesia, MUA, or arthroscopic capsular release in refractory cases. Conclusion. Frozen shoulder is a fibro-inflammatory disorder involving synovial hyperplasia, capsular fibrosis, and neurogenic inflammation. While most cases resolve spontaneously, early intervention can reduce disability. Further research is needed into anti-fibrotic therapies targeting TGF-beta and myofibroblast activity. I hope you must like the video. For such types of health consciousness video, do subscribe our YouTube channel. Share the video to your loved ones. Give suggestions for the improvement of our contents. If you are watching this video on Facebook or Instagram, then do like and follow our page. Thank you so much.